public health registrar in the public health team. I've been in Sandwell since March, so pretty much throughout this whole period of the COVID-19 outbreak pandemic, and I'm contributing one of this course's modules today on vulnerable groups and COVID-19. So this is about people who are vulnerable to COVID, either of becoming very ill from COVID or of getting COVID. So the aims of objectives of today is to cover why understanding who's vulnerable matters in how we respond to COVID, what types of vulnerability we know about, and emerging evidence of different types of vulnerability, and then some coverage of vulnerability in Sandwell, so what we know about certain groups clinically or for demographic reasons that have factors that make them more vulnerable to COVID-19, and then a bit about what the advice is now for people who have risk factors and for whom we want them to protect themselves or take action that is different, as in like the shielding group, to other people in the community. One thing to note is that when we're talking about emerging evidence, a lot of that is not necessarily, it's more descriptive statistics than it is analytical. So when we talk about it, it's often an association, and association doesn't always mean causation. And a lot of this evidence is emerging, and over time we might come to have a better understanding of what the explanation is for that association. So, well, I know you've all got chat boxes, so you can't actually jump in very easily. But if you could take a minute to think about what we understand or how we can use a better understanding of who's vulnerable to COVID-19, and maybe input some comments in the chat box. And Joe, am I able to see the chat box at the same time? I can't remember what you said.
I don't think you can, Alice, unless you're really techie, and I don't know about it. So if people do and you don't mind, I will speak for them unless they want to come on mic.
Thanks. Yeah. So if you just take a minute and have a think about what use we could make of this understanding. Have any comments appeared, Joe?
Nothing as yet, no.
No comments?
No comments yet.
Maybe this is a little bit abstract. So,
oh, beg your pardon, Richard Cooksey and Paul Fisher as well. Oh, and Karen, we've got a few coming through now, beg your pardon. So Richard Cooksey's asked work which groups to protect.
Yeah.
And Paul Fisher, target our interventions / communication. And Karen has asked, target the support we offer to specific groups of people.
Brilliant, yeah, those are all separate sort of things that we can use it for. So as was it Paul mentioned there, so targeting communications to certain groups so that we know and how we communicate as well, using the right mediums, whether that's language differences or coping with people's disabilities and adapting messages according to learning disability or sight or hearing loss, and then targeting public health interventions, and these may not necessarily be COVID specific interventions. It could be things like weight management, given our understanding that obesity is puts people at much higher risk of bad outcomes from COVID-19. It could also be for prioritising vaccinations and occupational health assessments as and when those have been when we have a vaccine, there might be certain groups that we want to reach first. And equally, sooner than that, we'll probably have individualised occupational health assessments, and who we try and reach first with those will be influenced by their vulnerabilities. And to researchers, this is a really useful knowledge base to then begin to model what the impact of different population level interventions will be. And one thing as well that could also be done is, rather than just tailoring generic communications, we could also develop online tools where people can start to risk assess their own vulnerabilities. And so that's another potential use for engaging people more in how they manage their risk. So in terms of types of vulnerability, we're talking here about both clinically vulnerable and non-clinical vulnerabilities. So clinical ones are things that put people at greater risk of serious illness if they become infected with COVID-19. And non-clinical ones we call functional vulnerabilities, and those are people who are less able to help themselves if they become sick with COVID-19. There are two broad groups of clinically vulnerable. So this is the shielding list. So this was the list drawn up at the start of the pandemic, on which GPs then identified patients on their lists who were affected by one of these conditions, and then they wrote to them and asked them to shield, i.e. stay at home and cut off most contact with the outside world for a long period, all the way through to the end of this month. They've been asked to shield. And without explaining everyone on this list, broadly speaking, these are all people who have conditions or taking treatments which suppress their immune system. And immunology was covered last week, I think, by Neil. So these are people whose immune systems are just not as able. So if you've had an organ transplant, people will be taking drugs that suppress their immune systems to prevent them from rejecting the organ for the rest of their lives, usually. And so they're much more susceptible to COVID, and both catching it and becoming very ill if they develop it. And similarly, people who've got who are having treatment for cancer, like chemotherapy or radiotherapy, those also suppress your immune system whilst you're having them, and steroids are a drug that do the same. And most of that is, most of this list is those people. There's also people with a serious heart condition or pregnant, but the guidance for people who are pregnant has changed slightly now, so it's only in the last trimester. And the moderate risk group are people who are suffering with other conditions or who are just over 70. So this list originally was just drawn on the basis of people who received the flu vaccine, and broadly speaking, a lot of this still holds true, but we'll come on to the emerging evidence next. But these are people who are over 70 or living with certain chronic conditions that put them at greater risk of complications if they develop COVID. And I've got a few stats here on what those look like in Sandwell, because we actually, in Sandwell, being a very deprived area, many of these conditions are more prevalent because poor health and deprivation go hand in hand. So Sandwell has a higher rate than average for England of people living with diabetes and chronic heart disease and certain cancers. So there's estimated to be about 50,000 people in Sandwell who are living with diabetes, and about 10,000 of these people are not diagnosed. So that's really worth bearing in mind when we think about public messaging, because sometimes it's not only about people with known risk factors, but it's about getting people diagnosed so that we know their risk factors. There's about 8,500 people living with cancer. There are about 3% of the population have chronic heart disease, and there's about 15,000 people living with chronic kidney disease. So as you can imagine, in a population of about 340,000 or so, it's a large proportion of the population are living with one or more of these conditions. And we'll come on to a bit more about that afterwards. And in terms of children, what's been interesting with the pandemic is that whilst at the start, a lot of children with chronic conditions like asthma and diabetes and epilepsy were encouraged to shield, it's actually been the case that there's been lower than average mortality in children under 18s through the course of the pandemic. And so most under 18s are going to come off the shielding list from the end of this month, which means they can go back to school in September. And it will only be in rare cases where somebody's got a very complex condition and their doctor recommends it, that a child will need to continue to shield. And then this is more of the emergent evidence about who's at risk from COVID. And what you'll notice here, there's a few categories I've listed here, which I'll go on to explain a bit. But a lot of this isn't so much about conditions that people are living with and health problems, but actually about demographic factors that have really come to the fore. So age was always seen as a risk factor, because when people get older, their immune systems are weaker and they're more likely to be living with other conditions. And people over 70 were always advised to shield or take precautions. But the actual excess mortality has been far greater than you'd normally get in a flu season for people over 70, or even over 60 is where the risk really starts to rise. Sex and ethnicity and deprivation, none of these are clinical factors, but they've all been shown to be very significant for altering people's risk of bad outcomes if they get COVID, or even of getting COVID in some groups. So this chart is looking at the rate of hospitalizations for men and women. So we'll start with sex here, and you can see that the in the left-hand chart there are more men than women being admitted to hospital. So this is lower level of care. So this is just being admitted to hospital. It doesn't mean that you've had to receive intensive care. And on the right-hand side, you'll see that there are this is the people admitted to critical care, where the difference between men and women is much greater, and particularly this is younger adults, because once people are over 80, the intensiveness of intensive care, the fact that once people are put into intensive care, they're often put into an induced coma or put on a ventilator, means that people over 80 are often not taken to intensive care, because it's just not seen as beneficial. The harms outweigh the benefits. But in younger adults, the excess deaths among, the number of deaths is far greater among men than women. So the people who were 80 or older were 70 times more likely to die than people who were aged under 40, and the excess mortality among men was twice that of women. So this is from analysis of critical care data in England. And then this is an age-sex pyramid, where what we see is the distribution of deaths from COVID. Now the excess mortality here among much older adults is not as significant, but among the 60 to 80-year-old group, you can see a huge, or even 40 to 80, again, the number of deaths among men is about twice that of women. And there have been potential explanations put forward for this, but I'm not sure that any of them have been verified yet. One is the idea that a cell surface protein called ACE2, which is found on the surface of cells in the respiratory tract, is more expressed more in men than women, partly because men are more likely to smoke. And possibly that's an explanation, because the virus exploits that cell surface protein in order to infect cells. There's also the possibility that there's a protein women express a lot more than men, which helps them fight this particular group of viruses. And the reason they express it more is because they've got 2 X chromosomes, and it's expressed on the X chromosome. And that might make women better able to protect themselves against, or their immune system better able to fight COVID. It's also just possible because men are more likely to have heart disease, high blood pressure, and liver disease, that can also make men more susceptible to adverse outcomes from COVID. This is Sandwell specifically, and as you can see, this isn't disaggregated by age and sex, but the deaths from COVID are much higher in older adults, and you can clearly see that it doesn't reflect at all the age distribution of the population, which is the green columns, versus the age distribution of deaths from COVID, which is the purple columns, and are clearly weighted towards people aged 70 and above. So obesity is another risk factor that's been identified, which, if you think back to the earlier slide about clinical risk factors, obesity wasn't on there as an independent risk factor, even if some of the things we associate with diabetes were on there. But even when adjusting for certain other risk factors, it's been found that people who are morbidly obese are much higher risk of death, about twice the risk of death of people who are normal weight. So 7.7% of patients who are critically ill in intensive care were morbidly obese, compared with 2.9% of the general population in a study about intensive care admissions. And the increase in risk goes up fairly gradually until you get above a BMI of 40, when it goes up very steeply to an excess risk of about, well, it's 2.27 to a hazard ratio of 2.27, which means that you've got about 2.25 times the risk of death from COVID if you're morbidly obese with a BMI of over 40. And in Sandwell, we don't really know how many people would be in that group, but it's about 71% of adults who are either overweight or obese, which is higher than the average for England. And how many of those are morbidly obese, as I say, we don't really know. But again, we may want to target weight loss interventions at people with higher excess weight. And diabetes has also been noted as a risk factor. And what you can see here is the sort of relationship between both diabetes and deprivation. So I'll come on to deprivation in a moment, but the percentage of deaths rises. Sorry, the percentage of deaths from COVID is has a social gradient. So people in more deprived areas are more likely to die from COVID. But in particular, with diabetes, the people in deprived areas with diabetes are much more likely to die of COVID than people in less deprived areas. And this also varies by ethnic group. So people of white ethnicity, of deaths among people of white ethnicity, 18% were found to have COVID, were found to have diabetes. Whereas in deaths of people of Asian ethnicity, 43% had diabetes, and 45% of people from black ethnic groups. And this partly reflects higher rates of diabetes in those communities. But as I say, a lot of this is descriptive at this stage, so we don't yet have a really detailed understanding of the relationship between all these different risk factors and what causes what. But yeah, in Sandwell, as I mentioned before, we have about 50,000 people, so a significant proportion, about 11% of the population, have diabetes. So a very significant risk factor locally. Now, I don't find any particularly good charts on ethnicity. There are some out there, and I've come on to some about Sandwell in particular, and about our ethnic mix in Sandwell. But there has been analysis of as I'm sure be aware, that BAME communities are at higher risk of death from COVID. And the some analysis has shown that even when you account for the effects of, say, sex and age and deprivation, certain groups really stand out. In particular, Bangladeshi community are the most affected. So PHE did a big study, found that the people of Bangladeshi ethnicity had about twice the risk of death from COVID of people of white British ethnicity. And then people of Chinese, Indian, Pakistani, Caribbean or black ethnicities had 10 to 15% higher risk of death from COVID. So again, the explanations for these are not agreed yet. There's been multiple different analyses, and where I say that the excess deaths are much greater in those groups, that's not accounting for occupations and their exposure to COVID or the diseases they might be living with or rates of obesity. But there has been analysis that does look at those risk factors, and that has found that that when you account for those risk factors like occupation and illness and obesity, the excess rates of COVID death are much lower, but they do still exist. So there's something some sort of residual risk factor that isn't fully explained. And in addition to this, as well as excess risk from death from COVID, there's also been excess deaths generally in the population in those communities, where even among females with lower overall risk of COVID, there were 3 times as many deaths in Black, mixed and other ethnic group communities among females than among white females. So this chart is showing us the excess, the age standardised diagnosis rates by deprivation. So what this means is that where we've adjusted for different age profiles in different populations, like the fact that Sandwell has a slightly younger population than average, these are the rates of COVID, showing that in males and females, the rates of diagnoses are much higher in more deprived areas. So in the 20% most deprived areas, there are about 350 cases per 100,000 males, compared with about 190 in the least deprived areas. So deprivation is a really significant risk factor. And we're going to go on to discuss a bit about the factors that contribute to this, like occupation and housing and underlying health. And but just to say before I go on to that, that one study that did look at underlying health and deaths from COVID and deprivation found that it couldn't really be explained just by underlying health conditions. So it is to do with those other vulnerabilities that come from perhaps from occupation and housing and poverty, rather than just health problems that people have been diagnosed with. So this chart is similar data to what we've seen above, but this is about deaths generally, and then deaths from COVID. And it shows that on the right-hand side of the chart, where you're looking at more deprived communities, there's generally more people are more likely to die of diseases than in more affluent communities, but they're disproportionately more likely to die of COVID. So if you look at the blue columns, so whereas in the least deprived areas during the pandemic, there's been roughly the same number of deaths from COVID as there has been from other causes. In deprived areas, the COVID deaths have been much higher than deaths from other causes. And the mortality rates from COVID in the most deprived areas were more than double the least deprived areas. So I'm just going to go on to talk a bit about these factors now in Sandwell, and so how this data impacts the Sandwell community, or what this means for Sandwell. So many of you will be very aware Sandwell is a deprived area, and so it's about 12th most deprived local authority in England. It is the most deprived in the Black Country, and about 20% of the population are in the 10% most deprived areas in the country. So these little cells are showing the little small areas marked on here are lower super output areas with a population of about 2,000 people each. And the majority of the population are in the lower 50% of most deprived areas in the country. Ethnicity, we have a much higher, much larger BAME community than in other parts of the country, and certain wards or towns have a much greater representation of BAME community than others. So up to 80% of people in St Paul's, Soho and Victoria are of Black and minority ethnic groups, and in West Bromwich and Smethwick, you can see from this chart that the majority are BAME community. So this will potentially impact where we target public health messaging, how we communicate it, thinking about language barriers and other how we communicate messages. Actually, I'm going to skip that slide because I think we've covered it really just there. But then also looking at occupation. The Office of National Statistics have done an analysis of deaths looking at occupation, and they found that men in particular that work as security guards and taxi drivers and chauffeurs and drivers, and also in any kind of public facing role like chefs or sales and retail and construction and meat processing as well, and generally processing plants, have had much higher rates of death from COVID. And this is also true for women in social care. And you can see here the excess deaths that have been found in some of those groups. So in caring services, the 73% of excess deaths due to COVID were in caring services, and similarly with other no, sorry, the final column on this chart, I'm not entirely sure what those numbers are referring to, but in the first column on excess deaths in 2020, you can see that there have been, high numbers of deaths in certain occupations, as well as in people who just are not employed, which is likely to be retired people largely. And this is how that's reflected in Sandwell. So this data is showing the percentage of people of different ethnic groups in different occupations. Partly contributes to some explanation of that relationship between ethnicity and risk from COVID, in that people from BAME communities are much more likely to be in public facing roles or in jobs where they're working in close contact with other people, like in processing plants and as machine operatives. And again, going back to the previous slide, so in Sandwell, the BAME community are also generally younger rather than the white community. So age doesn't really explain why that would be a risk factor for COVID. But if we are looking at age, this is the number of people aged over 17, just to show that varies a lot by town as well. I don't know if you can see the whole slide here, but in West Bromwich, there are about twice as many people over the age of 70 than in Smethwick. So thinking about the steep age gradient in risk of COVID, that will vary according to which town people are living in. Going back to the previous slide about chronic conditions in COVID, this is just showing the number of people aged over 70. So just to sort of give an indication of the combined effect of chronic conditions and age, that among people over 70, a large number of them are living with a chronic condition as well. So these are just absolute numbers. About 7,000 people over 70 have diabetes, although that's not such a strongly age-related disease, whereas cancer and COPD and kidney disease, again, that those are prevalent among people over 70, and people are much more likely to develop them as they get older. So all of these could be used to inform how we risk assess individuals for their work, and that's going to be the topic of a later module that Neil and I are going to be presenting, so I won't talk much about those here. But just to say that there's a lot of work, there's risk assessments that have already been developed for individuals to look at their own risk, but there's a lot of work as well to try and develop a standardised one that can be used. And in the meantime, we are also working on one in Sandwell ahead of anything that will be produced nationally, to try and develop one for schools and workplaces and settings where people are more likely to be exposed to COVID. And a little bit about people who are functionally vulnerable. So this could be people who are less able to help themselves. So it could be people who've got disability or mental or cognitive impairments, sensory impairments, people who are homeless, and also children and older people who are not so able to help themselves. But it's just important to note that a lot of those people will also overlap with the clinically vulnerable group. And those people who are functionally vulnerable are more likely to be living with health conditions that make them clinically vulnerable. But this is also worth noting when you think about the impacts of lockdown on services for people who've got functional vulnerabilities, that some of them will be less able to receive home visits, and we'll come on to the impact of that, what that might mean for their risk, not only from COVID, but also from other diseases as well. There's been found to be a higher number of people who are homeless developing COVID-19. I don't have figures on mortality among people who are homeless, and the data quality is quite poor. But yeah, there's been a higher rate of people who are homeless diagnosed with COVID since the start of the outbreak, the pandemic. And at the start of the pandemic, a task force was created to try and get everyone in, as it was called, and house all the rough sleepers, which has been successful in the sense that the vast majority of rough sleepers have been accommodated, and that's true in Sandwell as well. And testing and treating of people who are homeless has been incorporated into the outbreak plan in Sandwell. So their risk from COVID is hopefully partly mitigated by all of that. But I'd encourage you to have a look at Sandwell outbreak plan, which I've linked to at the end of the presentation, to sort of find out more about what we're doing locally to enable testing and access to treatment and accommodation as well. More importantly, in care homes in England have accounted for about 27% of all deaths from COVID, which is obviously far, far in excess, as you'll all be aware, I'm sure already, of what would be expected in the population. In Sandwell, there's been about 39 outbreaks to date, but what you'll see from this chart is that those have, this is slightly out of date now, it could be more up to date actually, but the number of outbreaks in care homes has declined steeply, and as far as I know, we haven't had any new cases in the last week or thereabouts in the care homes. So it's been a very successful programme of work to contain outbreaks in Sandwell, and that's involved really close contact with all care homes, regular calls, making sure they're using the right PPE, that they know how to use it, that they can access it, that people are getting tested and treated, and that the right isolation procedures are being followed. So that's been a success story in Sandwell, that it's come down eventually. But this has been the on the x-axis here, we've got the weeks from the start of the year, and then the number of deaths in care homes in Sandwell specifically. You can see that around weeks 14 to 19, the red part of the column represents the number of deaths from COVID, and the white part of the column represents the number of deaths from other causes, and everything above the green line represents excess deaths over and above what you'd expect in the average year. And this reflects similar picture to the national picture, which is that about half, just under half of the excess is attributable to COVID. So which means that there's a lot of people in care homes who've died of either because they haven't received the same services during COVID, possibly, or also because they just haven't been diagnosed with COVID but have actually had COVID. But basically a lot of excess deaths in care homes have not been attributed to COVID during this period. And whether that's because people are being told to not come to hospital or they're not receiving home visits, we don't really know, but it's quite concerning. Moving on to another risk factor here, this is the general population, and looking at the, this sort of comes back a bit to that relationship between deprivation and risk of COVID. So, and also ethnicity. So people from the BAME community are much higher, more likely to be living in overcrowded accommodation. And this is Sandwell specifically. So Sandwell has higher rates of overcrowding, and this is disproportionately among people from BAME ethnicity. There's a figure on here, about 30% of Bangladeshi households are overcrowded, compared with only about 2% of white British households. But intergenerational living is another risk factor. So where you've got people who are over 70 living with people, younger adults who might be going out to work, then those older adults are going to really struggle to shield. So if you think that a lot of those older adults also living with diabetes and other conditions and are on the shielding list, they're going to have, it's much more difficult for them to protect themselves within their own home and practice social distancing. And Sandwell has the highest rate of intergenerational living outside London. So this disproportionately affects people in Sandwell. So that's just looked at, I've just gone over some of the demographic risk factors there in Sandwell. And just to quickly update on what the advice is now for people who've been told to shield. So these are the people in the clinically extremely vulnerable group, not just the more broadly moderately vulnerable group of people with a lot of chronic conditions. But essentially they've been told to stop shielding from the 1st of August, and some of the support that was available will cease, but some of it will continue. So they won't receive food parcels anymore, or medicine deliveries, but they may receive those via their local volunteer responders, but they won't receive it from the National Shielding Service, which was a independently run service. And they have been advised to try to continue practice social distancing, but I know it's been a cause of a lot of stress for people over how they do that when they'll no longer be eligible for as much support, and for many people their statutory sick pay entitlements will run out, because you can only receive statutory sick pay for I think about 6 months, just over 6 months. So those people will still be advised to shield, and I think a lot of employers will still continue to stay at home. And certainly where possible, anyone who was on the waiting list should be told to stay at home and work from home where that job allows it. And if their job absolutely doesn't allow them to work from home, every possible measure needs to be put in place to protect them at work. So that's just recapping what I've just said there. Finally, just to go on to the outbreak plan, and I mean, I could have put hundreds of logos here, but just to say that obviously to date there's already been a huge amount of support in Sandwell to support people in these vulnerable groups, people who are both clinically vulnerable and have those sort of functional vulnerabilities or demographic vulnerabilities. And in some cases this is, with practical support like the food parcels, and in some cases it's about communication and making sure that we're getting things out in the right language, and then coordinating volunteers who've been really active in Sandwell going out to support vulnerable groups. So there's been a huge amount of work already, but as the pandemic evolves and as say people come off the shielding list, or well, they'll still be on the list but they won't be advised to shield anymore, and as people as we move into the next phase of the pandemic response, these we need to think about how we're going to adapt all these services to make them sustainable and communicate the new messages that we need people to understand. There's also been a lot of engagement with the community to try and understand what people's experience has been during the lockdown in Sandwell, and this is just some quotes from feedback that was gathered in community engagement exercises, and just really highlights the way that it amplifies vulnerabilities to people, the lockdown itself as well as COVID. So it's worth just always bearing that in mind, that when we talk about vulnerability to COVID, we're actually talking about we need to go beyond just vulnerability to COVID and understand how the response to COVID impacts other vulnerabilities, like ability to access support if you're experiencing domestic violence, or if you've got mental health problems, or if you're a child in receipt of services from children's services. All of those are massively impacted by the lockdown and social distancing and guidance and PPE guidance. So I'm sure a lot of you will obviously be very aware of that from your work. And then finally, some suggestions for further reading if you want to know a bit more about these risk groups. So the outbreak plan shows you what the plan is for Sandwell, which hopefully a lot of you have read already. And then there's a couple of summary descriptive analyses here with the Public Health England's disparities review and Public Health England's report on the impact of COVID on BAME communities. And then the Open Safely study is the largest analysis in England of data using GP data and linking it to all sorts of hospital data and other demographic data to look at the outcomes for people with different risk factors. So it's a really useful summary. and it will. The last publication was May, so I'm sure the findings will evolve over time. And that's about it.